Good morning, everyone. We're so excited to have you here this morning. Hi, good morning. So welcome to our fourth Project Echo session for addressing barriers to healthcare and cancer prevention screenings for adults with developmental and intellectual disabilities. We're so excited to have everyone in our Zoom room this morning, and my name is Michelle Jansen. I'm the Community Outreach Coordinator here at Rutgers Cancer Institute of New Jersey. And as the state's only NCI designated comprehensive cancer center, our goal is always to prevent cancer before it starts. And in New Jersey, we know that cancer is actually the second leading cause of death. 1 in 2 men and 1 in 3 women within our state will develop cancer at some point in their lives. And we know that those with an intellectual or developmental disability experience greater health disparities and poorer outcomes when it does come to a cancer diagnosis. So before we introduce our moderators and presenters for this session, we would just like to share a few tidbits of information if this is your very first Project Echo series. We encourage everyone to have their cameras turned on if possible, just to encourage the flow of dialogue and the exchange of information as our session goes along today. And we just also like to offer the reminder that whenever we have a speaker, just be sure that your microphone is muted, just to minimize any potential background noise. But we do encourage you to definitely unmute yourself to provide feedback, suggestions anytime during the dialogue portion of our time today. We're also going to be monitoring the chat box. So if you want to pop a question into the chat box, we can definitely get that out to the speaker at any time during their presentations. So the first part of our Project Echo session today is going to involve an evidence-based presentation that's then going to really jumpstart us into an open conversation about best practices and developing solutions for common challenges that we may face in our practice and provision of services to individuals with special needs. Everyone in our room today is an expert in their own right and through their own unique skill set and experiences. Our goal is really to bring all of these combined skill sets together into one place where we can discover new approaches, build a set of evidence-based practices, as well as to share resources and connections to enhance the care that we provide in our different disciplines and respective professions. So I'd like to introduce our panel of moderators for each Project Echo session. This is what we refer to as the Project Echo Hub, and you'll see us here for the next 4 sessions. And our goal is really just to help guide the discussions, moderate the chat box, and really get the conversation flowing. We're also going to be sharing a box folder each week with you where you'll have ongoing access to any PowerPoint presentations, and we also build out resource guides following each presentation every week. First up, I would love to introduce my wonderful colleague, Sherilyn Cognetti, who is the current president of the North Jersey Health Collaborative. So Sherry, I'm going to pass the microphone over to you.
Thank you. As president of the collaborative, I value the strength of partnerships in addressing the health of our communities. I welcome you taking the time from your very important jobs to join us in the discussion today to work with adults with intellectual and developmental disabilities. Thank you. I would now like to introduce you to the Executive Director of the North Jersey Health Collaborative, Laura O'Reilly-Stanzelis.
Thank you very much. Welcome, everybody. Great to see all of these familiar faces and new faces. I am the ED of the North Jersey Health Collaborative, a registered nurse who has worked for many years with individuals with developmental disabilities in a community setting. And I can tell you that these 3 speakers today work with such passion and serve individuals with great skill, and it's an honor to have them share their experiences with us so that we could help break down some of the barriers. Our first speaker today is Katie Swanson. Katie graduated with her associates in applied science from the County College of Morris in 2009 and has been a registered nurse at Sussex County ARC for 12 years. A year and a half ago, Katie was promoted to the Health and Nursing Care Administrator role and oversees the registered nurses and registered dietitian. Prior to SCARC, which is Sussex County ARC, Katie has professional experience caring for adults with developmental disabilities, working at Milford Manor Nursing Home, and as a direct support person at Department for Persons with Disabilities, DPD, which is where our second speaker, Ann, works. Katie, I will hand it over to you to share your screen, and each speaker is going to speak for 15 minutes, so I'm just going to be calling out time checks so that we stay on schedule.
Good morning. Thank you for that lovely introduction, Laura. I'm very excited to talk to everyone from just my experience and my perspective. Okay, I'm just going to pull up my screen. Can everyone see this?
And this is perfect, Katie.
Okay. All right, so I'm just going to speak briefly today about colorectal, cervical, and skin cancer screening barriers in adults with intellectual and developmental disabilities. So before I get started on that, I just wanted to give you some of my background. So SCARC was established in 1957. So we've been around, we've grown. We have 23 group homes in Sussex County, 5 supportive living apartments, 95 residents, and 8 day programs. Our 8-day programs are a mixture between our residential folks and external folks from Sussex County. We have 2 nurses that I oversee, and then there's myself, so there's 3 total that are currently in the community, but will be in day program and the community as we continue reopening. Then we have employment supports, family support, and recreation, and 2 sister corporations. We have Guardianship and SCARC Foundation, and I just left the website there in case you wanted to look into it further. Okay, so American Cancer Society gives us pretty straightforward screening recommendations. Age 25 to 35 screening recommendations are cervical cancer screening recommended for people with the cervix beginning at age 25. Age 40 to 49 screening recommendations for breast cancer are recommended beginning at the age 45 with the option to start at age 40. Cervical cancer, again, screening recommended for people with a cervix. Colorectal cancer screening recommended for anyone beginning at the age of 45. And at 45, African Americans should discuss prostate cancer screenings with a doctor. Then age 50 plus screening recommendations, breast cancer screening recommended, cervical cancer, colorectal, and people who currently smoke or formerly smoke should discuss lung cancer screening with a doctor and discuss prostate cancer screening with a doctor also. So this is for all. Now to talk about the disparities in percentages for adults with developmental disabilities versus the general population. So for breast cancer screening, the ID folks is 67 to 79% versus general population of 70 to 83%. Cervical cancer, our folks 77 to 82, general 83 to 87. And then what was really interesting about colorectal screening is because the stats were kind of all over the place. Some were saying that there was actually more screening, maybe because people have guardians or, you know, they may be instructed by their doctor and they listen to actually have that screening performed. And there was other studies that are the same and other studies that there was less. So it was kind of a mixed bag there. So given those percentages that I just showed you, concerns about the accessibility and quality of cancer-related care for people with ID have been substantiated by studies indicating lower participation rates in cancer screening, detection of cancer at higher tumor stages, different distribution patterns across affected organs, and cancer-related mortality at a younger age compared to non-ID reference groups. So in other words, our guys aren't getting screened the same. They're finding out later, and we're not, and it's found out later, and that there's mortality at a younger age. So this is just a chart that basically just shows what I just talked about. The dark is the ID, and the white is the general population. So you'll see significant less screening. And my references are at the end if you wanted to know where I got all these stats. So something interesting is individuals with Down syndrome are less likely to have certain cancers. So that affects kind of our data, right? It affects, are they getting less screening? Is it happening less? Is it a combination? So I did want to point out that, though I am focusing on Down syndrome, personally speaking, only 12 out of 95 of the individuals I serve have Down syndrome. So it's definitely not the majority, it's the minority. So yes, people with Down syndrome are highly protected for most solid tumor cancers, such as breast, uterine, and prostate cancers. However, people with Down syndrome are much more likely to develop certain leukemias, one of the key blood cancers found predominantly in children for the general population. Okay, so less screening for adults with disabilities, including ID, and less incidence. And then I also wanted to point out that I think this affects the data is screening, like when we talk about breast cancer screening. Yes, breast cancer is more common than cervical or colorectal. And I feel like there's a lot more attention and focus brought on breast cancer. So I think that when it comes to screening, mammographies occur more than PAPs. So I think that kind of influences some of the data as well. Less invasive than a PAP and more prevalent and more awareness. Those are my references. So next, I'm just going to pull up some of my examples. Okay. So the main question here is, what are the barriers to cervical, colorectal, and skin cancer screenings, and how can it be addressed? What happens in our group homes? What happens in our residential programs that we see that leads to the disparities between the population we serve and the general population? So I just wanted to paint a couple pictures to show you kind of what I've dealt with. So I have a 38-year-old woman with ID enters the gynecologist's office for an annual exam. The APN performs a blind cervical sweep in hopes to get cervical cells. She was negative for cancerous cells. Case closed, see you next year. So if the APN and the staff were more aware of the situation, she would have been treated differently. So it's different than if you or I went into the doctor's office. So according to the individual, she has a history of being raped in the past. And this was not in her chart, but it was confirmed by a colleague of mine. So that means there's incomplete documentation and medical history, incomplete family history due to lack of involvement. So these are all contributing factors to this, right? Incomplete sexual history and her inability to express that to the APN. Staff's lack of knowledge to her past. So it's not that they could have even advocated for her saying this because they were unaware of it. The APN assumed that there was no sexual activity because she had Down syndrome. That led to incomplete testing, no STD tests, and no abuse screening. We have our questionnaires that we fill out, do you feel safe at home? So the whole appointment is not the same as if you or I went. And that is really what I wanted to hammer home with this example, is that how can we expect someone to have complete medical care if this is how we go into the appointment? So let's rewind a little bit. Oh, the staff is running here. I'm the manager. I don't have time for this appointment because I have so many things. Here's the paper. Go to the doctor's office. This is the address. I'll see you later. So how many times have I shown up to an appointment to assist and the staff is brand new, trying to do their best, has no idea why they're even attending the appointment? Do you know why you're here today? Do you know why you're supporting this person at this appointment? And I get a blank stare. Is that staff's fault? No, they're doing the best they can. they're showing up, trying it, they're scrambling and trying to do the best they can. I see it in their face. So they were everyone is setting themselves up for failure. So reeling it back, what can we do? And to be honest, what I think the number one solution is staff and training, staff and support. If I was able to meet with each staff, which I actually did when I only had 2 group homes, now I have 23, so I'm unable to, is every time there was a new staff, I sat down. It might take a couple of days, and I would sit down and I would talk to them. This is this person's history. This is where you can reference back to it in case you forget this 5 pages I'm just talking to you about. This is why we are following up with this doctor. This is why she may feel this way. And I just kind of bring them into it, invest in them. And then I have trainings on how to complete a appointment. I know that sounds very simple, but there's 1,000 things going on. Even when I attend appointment, I have to really make my checklists and make sure I get everything out as fast as I can because I only have a couple minutes to speak, it's a difficult task. So if there was more support with the staff, if there were more nurses, if there were more trained management, if there were more training set up, if we were able to retain staff longer, I think that this would really kind of bridge the gap. Okay, so that's my cervical cancer example.
Just jumping in here, you have 4 minutes left.
Okay, thank you.
Just to keep us going. Thank
Yes.
you. This is excellent.
So a lot of the points I already made actually apply to the colorectal screening and the skin cancer screening, right? So there was no, when you are given instruction to go to another doctor, there was no referral for a dermatologist. Oh, why does this person have to see the dermatologist? There's no reported skin issues. Well, they've had extreme sun exposure, are fair skinned, but that discussion didn't even occur. This man has never even been on the exam table because he's in a wheelchair and he's heavy. The one female staff accompanying him is not going to cut it, even with the doctor's help. So there's no skin exams. There's no discussion on skin exams. There's not someone that say, hey, this person may need this. What do you think? It just kind of, oh, we put sunscreen on him, he's fine. So it's not just the doctor maybe not thinking it, it's because no one is advocating for it. So who can advocate? Who can think of this in a different perspective than I have, 15 minutes with this patient and it's not my number one priority. And then colorectal screening. So a lot of our folks have a hard time tolerating the prep, right? They need scripts for it. They can't be on thickened liquids with all the preps. And their signs and symptoms may not be the same as you or I. If I was having bowel incontinence issues, I would be on the horn. You know what I mean? I need help, please. This is not okay. This is not normal. Well, is that the same for our guys? Is someone saying that? Oh, they have ID. That's just them. Well, why do you think that? Is that necessarily true? Luckily enough in this person's home, there's staff that has been there long enough that are saying, this is not okay. This is not normal. And will advocate. But that may not have been the case if he were in a different group home, a different setting. So just something to think about with the staffing shortage and the lack of advocates. Some people have phenomenal guardians, right? And we don't have that issue. We have this, someone barking down the door on the doctor's office saying this is what we need, but that's not the case for all. So some suggested interventions: talk and train to the staff on the individual on a continuous basis. Discuss each individual status at staff meetings. What's going on with so-and-so? Have you seen this? I've seen this. because sometimes we're so busy with policies and blah, 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 that we forget about the core of what is important, the individuals.
We are at the 1 minute to go mark. Thank you.
And then allowing management a probationary period on how to complete appointments, how to train the individual to observe his or her own body. This is a normal bowel movement. This means you are dehydrated, you know, so just something simple that you and I may notice ourselves. Someone else might not have any idea what that means or what that indicates. Having lifts in larger examination rooms, getting in there. Can they be seen? Can we see all their skin? And advocate for screening for all. Those 15 minutes did go very fast. I'm so
They
sorry.
did. That was excellent. Thank you. Excellent. So copies of this presentation, the scenario briefing form and the slides will be shared with everybody, and we will definitely have you all back for round 2. Thank you very much for that. Our next speaker, and again, this is about 3 different perspectives to show similarities between the challenges they face and also identify differences. That was my timer just went off between the challenges that they face. Our next speaker is Annie Williams, and she received her nursing education at the College of Staten Island in 1990 and became a certified developmental disabilities nurse in 2013. Sorry. She received her bachelor's in the science of nursing at Thomas Edison State University 6 years ago. Annie has many years of experience in various types of nursing, but has found her passion at Catholic Charities Department for Persons with Disabilities, where she has been the agency nurse since 2008. Annie loves the people she serves and anticipates working with them for many years. They are very lucky, Annie. Annie,
Thank you.
You're on.
Thank you. Thank you. As Laura said, I work for Catholic Charities, and part of Catholic Charities includes Straight and Narrow, which is our addiction services, CFCS, which runs children's services. We also have food pantries, veteran services, and DPD, Department for Persons with Disabilities, which is where I work. Currently, we have 10 group homes for developmentally disabled adults. We have 2 supervised apartments and 1 adult day program. We have a total of 61 residential clients and another 62 that attend our day program called Grunert Center. We do have a lot of clients who are over 50. We actually have 44 clients that are over 50 and another 32 at our day program that are over 50. And this is where a lot of the screenings come in. I just wanted to speak a little bit about colorectal screening and some of the difficulties that we've encountered. You know, Katie gave you a great background, and she did speak a little bit about some of the same difficulties that we've discovered. And barriers to proper testing and outcomes, I think one of the more difficult things that we've seen is the difficulty with the PrEP. Our clients either don't comply with the PrEP. I mean, anybody who has undergone a colonoscopy knows what the PrEP is like, and it's not very pleasant. I can't say that I blame them for not wanting to either complete or even start the PrEP. So what we have is the individual may not be clear enough to complete the procedure. We've had clients return to be prepped again and then go back a second time. I mean, how horrible is that? We even had a gentleman who's in his late 50s that failed to complete the PrEP twice and actually had to be hospitalized for his preparation. And this is a gentleman who has a lot of behavioral issues surrounding his bowels. So it became very, very traumatic for him. You know, imagine being admitted to the hospital. Now you have people that you don't know administering the PrEP. We've used Cologuard in the past, where you send a stool specimen in, and we had 3 people who we have done that with, 2 ladies in their 60s and 1 gentleman in his 50s, and all 3 came back inconclusive, and they had to do the PrEP again. They had to do the colonoscopy anyway. So that didn't really help us. In addition to the difficulties with the PrEP is actually finding a GI practitioner that will take care of our clients. Many specialists, not just GI, don't accept IDD patients. They, I think, have a fear of dealing with the population, and they don't want to manage any of the difficulties that are associated with them. For instance, being nonverbal. How do you get information from the client with signs and symptoms or how they're feeling if they're nonverbal. We may have someone who is combative or doesn't cooperate. And a lot of specialists and general practitioners, I feel, don't want to take the time needed to get to know the clients and gain their trust, which is a big part of it. And accessibility. Katie mentioned about having somebody in a wheelchair that was never given a skin exam. We find the same things. We have clients in wheelchairs. There's no lifts in the offices. Some don't even have ramps to get a client up into the office for an exam. Another bad is the insurance. We have our clients all have a Medicaid HMO. Most of our clients also have Medicare. And we're finding that a lot of doctors don't want to take those dual eligibles. The reimbursement rate is not that good, or they're not in network with one of the Medicaid HMOs, so they won't see our clients at all. The other issue is paperwork. A lot of the doctors, I mean, we all know the paperwork end is difficult. Everything that the doctor says has to be written down. And a lot of the physicians don't want to help us out with that. You know, just take Tylenol, they'll tell us. Well, we need that in writing. And well, it's over the counter. And we wind up into that back and forth. So it becomes very frustrating, very time consuming for the staff. We have found some GIs that we are able to work with. Unfortunately, they're kind of far away. So now we also run into the problem of staff time. We're losing staff for that 45, 50-minute ride back and forth to the doctor. And it just becomes a whole big mess. There are a lot of barriers, I think, and that's just touching on colorectal screenings. I also wanted to speak about dementia, which unfortunately we have been finding a lot of our clients are experiencing onset of dementia. We especially see this in our Down syndrome clients. As many of you may know, Alzheimer's dementia is the most common form. It's not a normal part of aging. And eventually it interferes with every aspect of daily functioning with our clients, from hygiene to eating to sleeping. And even though those with IDD are not more likely to develop Alzheimer's than the general population, those with Down syndrome are, and they can be up to 5 times more likely to develop this disease. There really is no definitive reason as to why this is, but possibilities include longevity. All of us, we're all living a lot longer than we used to. And having those with Down syndrome that are living well into their 50s and 60s. We even have a gentleman that just celebrated his 70th birthday with Downs. We're finding that this is happening more in them because they are living longer. And another reason is also with Down syndrome, the 21st chromosome, they have a 3rd copy. And they have found that the gene associated with the development of Alzheimer's disease is found on that 21st chromosome. So that could be another reason. Some of the signs and symptoms, the hallmark feature is the loss of daily living skills. They forget routines that they have done for many, many years. And it's very hard for them to learn and retain new information and new skills. Some may develop seizure disorders, start with incontinence. Return of earlier behavior. We've seen this in a few of our clients. Behaviors that they haven't manifested for decades are now starting to return. It's like they're almost regressing. Another thing we have seen is loss of depth perception, loss of balance, and they can't follow multiple step commands. You know, it's very traumatic, not only for the clients, but for the other staff and also for the other housemates as well. So what are barriers that we're finding? Well, one barrier that we're finding is actually getting a well-documented baseline status on our clients before any symptoms develop. The reason why we want to do that is because a lot of the changes that we see in those with Alzheimer's are very subtle. So having a baseline can help us decide whether we're actually seeing a change that's related to a cognitive disability, a cognitive issue, or if it might be related to something else. Currently at DPD, we did find a geriatric neuropsychologist that helps us with these baseline evaluations. And we've had success with this gentleman helping us out, and we're able to determine whether it's a medical issue that's causing changes that we're noticing, or if it really is something, a cognitive decline. Other main barriers, I think, to Alzheimer's evaluation are the exam itself. We mentioned a few of them: accessibility, getting somebody to the doctor's office, actually being able to get them up on the table for an exam, compliance with the exams. A lot of clients are fearful. I mentioned that it's hard for the doctors to actually gain that trust and take the time to make our clients feel comfortable. Our individuals may have a poor understanding of what's going on, or behavioral issues that prevent them from cooperating fully. Also, medical history. We have clients whose families are no longer with us, so we don't have access to them, or families that are not involved. Katie mentioned that also. We don't have that resource to tell us what kind of issues are in the family. Did anybody have cognitive issues? Did anybody have dementia? We don't know. We also have a lot of clients that still have come from developmental centers, whether in the past or now that a lot of developmental centers are closing. So we just don't know. And what this leads to is, because of the subtlety and the symptoms, subtlety and changes that we see, and all of these barriers, by the time we realize something is going on, their clients are usually in their middle to late stages of Alzheimer's. It's already progressed pretty much. We may not really notice, because a lot of our clients are very routine oriented, and they know to get their basket of their supplies. They go in the bathroom, they brush their teeth, they brush their hair, they get ready for work. We may not notice if now they're having difficulty maybe unscrewing the cap of the toothpaste, or they're using a comb instead of a brush, or they're not putting their belt on because they forgot how to put a belt on. A lot of these things are very subtle and we might not notice.
Yeah.
Also, staff turnover. We don't have a continuity of staff, unfortunately. And something that I may notice as somebody who's been working here for 13 years, someone might not, because they just started, or because of some staff shortages. We have others that work in multiple homes. So going from home to home, you're not going to notice these subtleties with the clients, unfortunately. And with the late diagnosis, this makes medications ineffective. The other problem with medications is they haven't been tested on people with Down syndrome. I don't know if they really work, to be honest with you. The people that we have had that have been on medications like Remeron or Aricept, they tend to have a lot of GI symptoms and they wind up being discontinued.
Yeah.
So I don't know whether these medications work. I really can't say. From my perspective, they have not. So, it's pretty sad when it comes to that.
Edie, we're at the 3-minute mark.
You got it. Assessment of someone with IDD is very complex. There are many different reasons why someone might be showing signs that are similar to Alzheimer's, multiple medications that they're on with many side effects. There are many disorders that can mimic Alzheimer's, like vitamin deficiencies, thyroid issues, vascular issues, and this can lead to a misdiagnosis. There's also mental health issues that could account for changes in behavior that we may think is related to Alzheimer's, but is not. And as a result, diagnosis is often delayed, or the person is completely misdiagnosed. Other barriers are that our clients sometimes have difficulty reporting those signs and symptoms that they're feeling. They just can't express what is going on. And a lot of the tools that doctors do use to assess the general population for Alzheimer's have not been developed for those with IDD. The National Task Group on IDD and Dementia does have a tool for those with IDD, but it's really just for baseline. It's not something that you can keep doing to notice if there are changes. So what do we do? As Katie said, I think we need to establish training, not just for our DSPs and our nurses, but also in medical schools, for nurse practitioners, for physician assistants. I think that a lot more practitioners need to know what is going on with this population and how to actively work with them and work with them properly. We need to work on staff retention. That's a big thing. We have a very big staff turnover. We have a group of people who've been here forever, and then another group of people who just seem to constantly turn over. You know, homes may not be accessible. We have some great group homes, but people, when they moved in, they were much younger. Now they're older. They may be having those perception difficulties with vision. They can't go up and down the stairs to their bedroom anymore. And our DSPs really are just not prepared to work with them. You know, I do as many trainings as I can, but with the turnover, it does become very difficult to keep that training updated.
We're at the 1 minute mark.
Okay.
Not to put pressure on you.
And everybody's getting older. Our residents are getting older. Our staff is getting older, and it's just becoming a little more difficult. So anyway, I'll stop. I do have a little bit more, but I will stop. And those are just some of the barriers that we found with Alzheimer's and also with colorectal screening. And thank you so much.
Thank you. And thank you. And we'd love to have you back when we roll out our series of colorectal cancer screening. The materials, again, will be in the Dropbox. Bev Roberts from ARC of New Jersey put something in the chat about a free webinar this Thursday, October 7th. She will email the information to us and we will get it out to all of you. Presented by the National Task Group on Intellectual Disabilities and Dementia Practices. So thank you, everybody. This is going so fast and there's so much to cover, but it's inspiring because we in this room are the people that can make a difference and advocate for training, education, best practice for people with disabilities. So thank you. Next up is Maria Eisenberger, RN. She's with the Jewish Association for Developmental Disabilities in Paramus, New Jersey. Maria began her career as a nurse working in a school with children with a wide range of special needs. Her 8 years as the medical coordinator at JADD, which is the Jewish Association for Developmental Disabilities, she oversees all aspects for healthcare for the individuals in their residential homes and apartments. Maria educates the direct support professionals on a wide array of topics related to health, well-being, and the many aspects of therapeutic support. She interfaces with physicians, nurses, pharmacists, and other healthcare providers to ensure the coordination and synthesization of all medical treatments and therapies. Throughout the pandemic, Maria spearheaded the efforts to institute mandatory COVID-19 testing. This effort resulted in 99% of JADD staff who are fully vaccinated. Maria's creativity, care, and compassion, combined with her nursing prowess, affords JADD the ability to deliver medical care with innovative vision. Great job, Maria, and we are really looking forward to hearing from you now. Okay, you're muted. We have to unmute you.
Sorry. Hi, thank you so much for that introduction, and thank you for giving me the opportunity to speak today. I'm just going to share my screen with you. Okay, can everyone see my screen?
Yep.
Okay, great. All right. So this month actually marks my 8-year anniversary with JAD, and I feel so blessed to be part of such a wonderful organization and to be working with so many amazing people in this amazing field, both the individuals and the staff. And I am not just saying that because some of my coworkers are on the Zoom. It's really an incredible organization, and I'm so excited to tell you first a little bit about JAD. So JAD is a not-for-profit organization, collaborates with the public and private sectors in achieving a full community life for individuals with disabilities, one person at a time. JAD provides residential opportunities in accordance with Jewish law, outreach, and vocational opportunities. The following core operating values influence the culture and public image of JED. So in terms of traditional Jewish values, JED services are first and foremost based on Jewish traditions. So I have a couple of pictures here, actually from September, where we celebrated some of our Jewish high holy days. The picture on the right, you can see shofar blowing at one of our beautiful group homes that is traditional between Rosh Hashanah and Yom Kippur. Picture on the left, you can see some of our consumers enjoying a meal in a sukkah, where it's customary to eat during the holiday of Sukkot. Here are some more of our mission and core values. JED has 7 group homes and 7 apartments across Bergen County. Our agency philosophy is all about normalization and integration, and we put an emphasis on individualized care. One of the programs JED runs is called Flowers by JED, which allows our individuals the opportunity not only to create beautiful floral arrangements, but also to sell them in the community. I could go on, but I know I only have 15 minutes and there are so many important topics to discuss with regards to barrier to healthcare in the IDD population. I'm going to start by discussing some examples of barriers I have experienced working in the field. So I'm going to review some cancer screening challenges, eye exams, dental and psychiatric care. Okay, so in terms of cancer screenings, as discussed, colonoscopies, the prep can really be a challenge, whether it's drinking the prep, the medication changes that happen prior to the procedure, the dietary restrictions. In terms of mammograms, the images can be difficult to obtain. Some of the consumers might have difficulty following direction. Pap smears, again, the procedure can be difficult to complete. In terms of eye exams, these are so important. We have screenings for vision, glaucoma, macular degeneration, diabetic retinopathy, just to name a few. Cataracts, surgical repair, lens measurements can really be a challenge. We had a consumer that had cataracts. She was having a really hard time recognizing people. She was falling. It was really affecting her quality of life. And we had to go to multiple doctors until we found one that was able to really work with her and get the measurements that he needed in order to complete the procedure. Our wonderful manager was in the room with her the entire time, making sure that she was comfortable and everything was going smoothly. And I have to tell you that since this procedure, it was really life-changing for her. Her quality of life improved tremendously. In terms of dental, many of you know that even just the daily hygiene can present a challenge, and it's really a medical intervention. Cleanings and dental procedures, I see very often that the recommendation is to have these done under general anesthesia, which carries its own risks and challenges. And then we also have the oral cancer screenings, which can also be difficult to complete. Psychiatric care, I think that I see sometimes where there's a difficulty between differentiating between a psychiatric diagnosis and the disability. In addition, poor communication may lead to ineffective therapy, which can then cause increased medication use, which leads me to the next point of polypharmacy. Many of our consumers are on multiple drugs, and this can lead to different interactions and side effects. And here we have our key stakeholders. So of course, the consumers, their families, the support agencies, medical professionals, diagnostic centers, DDD, pharmacies, the community, day programs, work environments, the hospitals, the emergency responders. There are so many factors here that are influenced by this. In terms of local related issues, staffing is a big one. Hiring, finding staff, especially now since COVID, it's been so difficult to find staff. And it's not just about finding staff, it's finding staff that can pass the screenings, that can pass the trainings, and that have that special something that makes them work well with the consumers. That's not easy. Training, again, such an important piece. Training the staff in the medical history of the consumers, training them on medication administration, how to administer medications properly to our consumers, and then training them on the difference between supporting the individuals versus doing for the individuals. And then again, turnover is huge. Turnover creates such a gap between, in the knowledge of the consumers. It affects the medical continuity of care. And it can also cause depression in the consumers, which then leads us back to the slide about the psychiatric care. Vehicles, transportation, having to juggle multiple schedules in the home, getting the consumers to the appointments, finding providers that not only take the insurance, but also understand our consumers' needs and can work with our consumers, and of course, are willing to complete all of the paperwork and documentation that IDD requires. And again, that is not an easy task. And also, we have to take accessibility into the equation. So not just in terms of mobility, but also visual, auditory, cognitive. And now we have some national related issues. So I'm going to start with education. Educating, what is the difference between a group home and a medical facility? I feel like not a lot of providers know the difference. At JED, I'm the only nurse. A lot of doctors, make recommendations assuming that the consumer is living in a medical facility that has, 24-hour nursing and a doctor on staff. So I think, just understanding the care and what we do in the group homes is really important. Also understanding how to care for an individual with a disability, understanding that individuals with disability might have a hard time with following direction. There might be physical barriers, there might be comorbidities, fears, sensory issues, touch sensitivity, and then of course, communication. How do we communicate effectively with an individual with a disability? We have to have patience. The procedure has to be explained prior and not just verbally. We really have to get a feel of like what exactly, is going to happen. And we may have to use iPads or other visual cues. In terms of attitude, medical care for individuals with disability. Again, just like Katie said, the appointments are not the same. And the standard of care should be the same for everyone. Understanding the worth of the individual, understanding and caring for the individual. And then of course, involving the individual in the process, just like we want to be involved in what is happening to us. It's so important to include the individual. What are their wants? What are their needs? What are their feelings? And then we have the social aspect, inclusion versus integration. And this happens to be my favorite slide because it's so important to understand the difference between these terms. And if you really look at this diagram, you see how, with integration, the colored balls are still in their own circle. Yes, they're in the bigger circle, but they are still separated. And with real inclusion, everyone is in the big circle together. Governance issues. Again, insurance. It's really hard to find the great doctors that take these insurances. DDD regulations, again, finding those doctors that will also cooperate with all of the paperwork that we need. And then the guiding philosophy of care support versus caregiver, supporting the individual versus doing for the individual. The consumer should be involved in their care. Legal issues, recognizing the rights of individuals with disabilities. Individual, okay, so we actually had a situation where one of our individuals was their own guardian, and he needed to have a dental procedure, and the dentist would not accept the signature of that individual as their own guardian, and he would not perform the procedure. So again, just recognizing the rights of the individuals. And that leads me to the point of guardians. You know, we work with many guardians, and it's really important that the guardians are able to separate, to set boundaries and really make decisions based on what's best for the individual. Okay, I'm running through this, making up time.
Yeah, we are at the 3-minute mark.
Okay, in terms of outcomes, okay, so what happens if we do nothing? What happens without intervention? We will end up with late detection of cancers. And again, at that point, the treatment is going to be more limited, and we may end up with a poor outcome. Decreased quality of life. For example, our consumer that had the cataract surgery. You know, what if we were not able to find that doctor that was able to work with her and complete the procedure? Decreased longevity, wasted resources. You know, if treatment would have been obtained with earlier detection, maybe the treatment would be less extensive. Lack of education, lack of acceptance. Again, segregation and exclusion instead of integration. And of course, misdiagnoses. All right, I just want to thank you all for listening and for giving me the opportunity to share my thoughts and experiences on this very important topic.
Thank you. Thank you so much for this great presentation. Thank you to all three. It feels like the time went so fast, and that's because there's so much to say and there's so much to be done. And stay tuned, because the North Jersey Health Collaborative, Sherry's like, yes, we're going to be opening up cross-collaborative discussions where we can work together and have conversations around this after this ECHO series, after our webinar series. This is going to be an ongoing process of the collaborative. So thank you, nurses, for the work that you do with your consumers, with our community during COVID. We are blessed to have you serving consumers with disabilities. Next week, our speaker will be me, Laura O'Reilly Stanzilis, and I will be talking about my experience with the National Center on Health, Physical Fitness and Disabilities, and my work in the Inclusive Health Coalition, talking about public health, healthcare, community health, and fitness programs on inclusivity and integrating, as Moria said, inclusion versus integration, right? Inclusion is not just about saying we include you, it's delivering ability appropriate services, programs, and initiatives in the community. So I hope to see you all again soon. Thank you to Michelle and Sherry for hosting this. Thank you for everybody for attending. And we've got 4 more weeks to go, and hope you can join us. Have a great day.
Thank you so much, everyone, for
Thank
joining,
you.
and you'll receive the resource guide and the box update later this week, and we look forward to seeing you next Tuesday at 8:30 a.m. Be well, everyone.